family that they are in their end stage and that they need to prepare, not only physically but emotionally and spiritually. We also provide emotional support to the family and loved ones after the patient's death, and that is a very, very important thing, because unlike most other branches of healthcare, when the patient dies, that's sort of the end of the relationship. For us, we maintain contact with the family and loved ones for a minimum of 13 months after the patient's death to make sure that they're okay. Next slide, please. Okay, so eligibility. This opens a real can of worms, because it's very hard for people to say, oh, I don't know who should be on hospice, and how do I know when they're ready? It is for anyone with an end-stage illness who has 6 months or less to live, as estimated by an MD. And that's where things start to get hairy, because a lot of practitioners say, well, I'm not qualified to judge that, therefore I'm not going to suggest hospice to this family. I'm not even going to talk about it. I'm not the doctor. There's no hospice police. We have had patients who've signed on with an anticipated life expectancy of 6 months or less and lived 2 years or longer. We've had patients who've signed on with a life expectancy of 6 months or less and lived 6 days. So it's not an exact science. We do give consideration to patients who don't have a clear-cut, quote-unquote, terminal diagnosis, but who have multiple illnesses, recent unintentional weight loss, decline in functional status or level of consciousness. And that's important because we're going to talk a little bit next about terminal illness and end-stage illness. So next slide, please. Okay, what does end-stage mean? What does terminal mean? So how do we define end stage? And how does this differ from terminal illness? I'm going to throw out for you folks, what are some diseases which people think of as terminal? I'd like you to throw some suggestions back at me of an idea of what you would consider to be a terminal illness. And I don't know if we can do that by unmuting or just have people type in.
One person said cancer.
Okay. Excellent answer, and we'll talk about that. Any other thoughts?
I think I can unmute all. It's not letting me unmute people for some reason. Oh, AIDS was another answer.
Not terminal. Used to be.
And I would argue that cancer depends on which cancer and what stage you're talking about, whether it's terminal. End stage renal failure, maybe. Oh, Elijah, can you talk?
Yes, I can talk. That was me. I just typed in stage 3 or 4 cancer. I heard someone say that it depends on, you know, the type of cancer that it is. Say for someone that is in their 90s and they have been diagnosed with leukemia, you know, chances are, I know that it's not a one-size-fits-all issue, you know, that can be solved. So it depends on the elderly person's health, you know, up to that point. If their immune system is able to respond well to the treatment that is being given. Heart failure, congestive heart failure, possibly.
Suzanne, are you hearing? Oh, I'm starting to wonder if I didn't somehow, when I was clicking around trying to get you guys to be able to talk, I might have somehow clicked something that would make Suzanne not be able to talk.
Okay.
Laura, are you there? I'm here. Oh, that's Lori. Laura Bingel? All right, so if everyone could just hang on for a minute. I have managed to somehow kick the speaker off. And let me email Laura real quickly. Laura, can you hear me?
We can hear you.
Oh,
Can you hear us?
no.
Yay,
Yes.
we're back.
Woo!
Okay.
Sorry about that, everyone.
That's okay. So the reason I bring this up is so that we can really look at terminal versus end stage, because quite often we get in our minds what is a terminal illness, what is not a terminal illness, and we proceed from there rather than looking at the whole picture. The sad truth of the matter is that most chronic illnesses will wind up being terminal. If a patient has, as you said, referencing the 90-year-old with the leukemia, there are a lot of factors involved in that, and you can't separate necessarily one from the other, but you do have to say that if somebody is 90, the likelihood of their dying in the next 6 months is considerably higher than somebody who is, say, 30. And therefore, when you look at the impact of another disease process on top of the age, or you look at, as I said in the last slide, somebody with multiple comorbidities, none of which is by itself a terminal illness, but multiplied by somebody, say, for example, with lung disease, heart disease, and kidney disease. Any of those three is going to make the others worse. So we need to think beyond the concept of terminal illness and non-terminal illness as to what indicates the end stage of an illness. That how do we know when a disease has gone from a chronic phase to a worsening phase to an end stage phase? So let's have the next slide, please. Okay, unfortunately my slides went a little bit out of order. I apologize. Can we go forward a couple more? Let's see, go one more. And then we'll come back to these two. One more. Okay. So let's talk about eligibility versus reality, because we're going to talk a bit about how we determine that end stage. People who are eligible for hospice can have a minimum of 6 months of hospice services. That's 180 days. Currently, the median length of stay for CareFirst hospice patients is 13 days. Think about that for a moment. 13 days between now and death. Is that enough time for this person to adjust physically, emotionally, spiritually to the fact that their end of life is imminent? Is that enough time for them to prepare for the other people in their lives to be cared for? And the answer is no. And the question is, if somebody has eligibility of 180 days to be on hospice service and they're only staying 13 days, what are they doing with the rest of that time? And these are not people who are hale, hearty, and healthy up until the last 13 days of their lives and are suddenly stricken by an end-stage illness. These are the people who spend the last 6 months of their lives bouncing from hospital to rehab to home and back again, each time spending longer and longer in the hospital and rehab and deriving less and less benefit simply because their disease is getting worse. Not because the care is substandard, but because ultimately there is a limit to how much we can do when a patient is in the end stage of their disease. So we are really trying to educate providers as to what end stage disease looks like so that they can recognize these patients and try to determine who among them are the frequent flyers for hospitalization because of non-compliance or lack of community support, and who are the people who are going back and forth because they are truly in the end stage of their disease, and what they really need is referral to hospice. Right now, less than 30% of people with terminal illness or end-stage illness in our area die on hospice. Studies have shown that 90% of the people with end-stage illness who are asked where they want to die say, I want to die at home. So clearly there's this huge gap. And I think the gap is caused by lack of communication and lack of recognition. So let's have the next slide, please. Okay. So let's look at our healthcare population. And we're all serving the same population regardless of what our program is. Nearly 1 in 2 Americans right now is living with chronic disease. 90% of our senior citizens, that's 36 million people, have at least one chronic disease. Of that group, 77% have 2 chronic conditions. 24%, almost a quarter, of those with chronic illness suffer from disability. That is a huge population of people who need help. All of the programs that we're all involved in now are geared towards helping those people receive appropriate community services. So how do we identify? Could I have the next slide, please? Okay, let's look at the statistics. I'm going to compare basically 100 years. Today, in America, the #1 cause of death is heart disease. And yet, when I say, give me a terminal illness, nobody leaps to heart disease. Everybody leaps to cancer. If you asked 100 people on the street, how worried are you about getting cancer? Most of them would probably say it scares them. If you said, how many of you are worried about heart disease, the numbers would be a lot lower. And yet heart disease is preventable. But most of us don't think that way. #2 cause of death in America is all cancers lumped together. That's a lot of different diseases, a lot of different disease processes across a lot of different body parts. #3 and rising is pulmonary disease. So if you look at the 3 largest causes of death in America, heart and lung disease are 2 of your biggest ones. And those are the people that we identify as chronically ill. And we often miss the boat in seeing when these people get to end stage. We keep trying to throw the chronic illness model at them with the result that they don't succeed. Life expectancy these days, and again, 2011 is the last year for which the data has been fully compiled, 78.2 years. People are expected to be disabled anywhere from weeks to years. If we go back over 100 years to the beginning of our current healthcare model, it was built around the idea that most people died from short-term diseases for which there was no cure. You got sick. If you got pneumonia, tuberculosis, or enteritis, you had them and you died. And so our entire medical model is built around short-term treatment of a disease, and now we have chronically ill people that the model doesn't fit. So next slide, please. And this is why we really need to change our thinking about end-stage illness. And I love this quote. It comes from Britain, which is where hospice comes from. Modern hospice originated there. And I'm going to read it out. It says, we suggest a move towards earlier consideration and more quote-unquote rainy day thinking, bringing an umbrella just in case it rains. This instinctive, anticipatory, and insurance-type thinking relates more to meeting likely needs and planning ahead, rather than focusing on trying to predict likely timescales, and should ensure that appropriate support and care can be mobilized. And again, we're all in the same business. How do we anticipate? How do we meet likely needs? How do we plan ahead? And it really changes the thinking. If you encounter somebody that you see as possibly being in an end stage of an illness, you're not going to be going to them and saying, I think you're going to die in 6 months. I think you need hospice. That's not what we're looking for. What we're looking for is you to be able to pick up on the signs that they are in an advanced illness and say, hey, it looks like things have been getting worse lately. It looks like you can't do a lot of the things you used to do. if this continues, what are your wishes? You know, what do you want to do? What treatment do you want? Have you set up an advance directive? I don't know if that's something that's in the scope of the programs that you folks are doing, but that's a huge, huge piece of everyone's care, is to set up an advance directive so that if things continue to get worse, we do exactly what you want done, and we don't do anything that you don't want done. Because the best way to keep people from getting aggressive treatment at the end of life is to not start to give it. It's much harder to take someone off a ventilator. It's much harder to discontinue a feeding tube than it is to put it in the first place. So by knowing what people want, by anticipating their needs, by recognizing an inevitable decline in health that does occur with most illnesses, we can help the patient be prepared, and we can be prepared. So next slide, please. Okay. Why is it important to talk about end of life? It's certainly not a happy topic. Nobody likes to be the one to talk about it. But research has shown that patients who had end-of-life discussions were less likely to receive aggressive treatment in the last 4 months of life. And I think that stat speaks for itself. Obviously, treatment done in the last 4 months of life did not sustain life. They were referred earlier for hospice, reported a better quality of life, reported greater emotional comfort, and the survivors reported less depression and distress. The same tack is that aggressive treatment at end of life was associated with worse quality of life and worse bereavement adjustment, simply because people didn't have time to prepare. They didn't have time to anticipate what was going to happen and be ready for it. So let's next slide, please. Okay, so how can you tell? How do you recognize when someone is moving towards end-stage illness? This question sounds ridiculously simple, but it's very accurate. Would you be surprised if the patient died within the next year? Would you be surprised if they died in the next several months or weeks? And if not, what measures might be taken now to improve the person's quality of life and to prepare for future decline? And that's the question. Not to say, again, I think you're going to die. I think you need to be on hospice. But to say, what things can we do now to prepare if the downward trend continues? What's our plan? And how do we make you do as well as you can for as long as you can? So next slide, please. Okay, what are some general indicators? Because again, my understanding is you folks are going to be working with the clientele over time, and you're going to need to be aware of what changes are indicative of an entrance to end-stage illness. The first one is decreasing activity, a decline in functional status. If you are working with someone and they can walk, and then in a couple months they need adaptive equipment, and then a couple months after that they need a wheelchair, if they need more and more assistance with self-care, that's an indicator that their sickness is getting worse and that plans need to be made. And I understand the goal of your program is to return people to the community and have them do well, absolutely. But we also need to be aware, if they start to decline, how to figure out if it's disease-related, if it's not, you know, what are the next steps if somebody decides they want to stay home? What services can you bring in? When is hospice appropriate? And one of the things to look at is the changes in activities of daily living. Multiple diseases, greatest predictor of morbidity and mortality. If somebody has, let's say, heart disease, they have CHF. If they have heart disease and stage 3 kidney disease, if they have heart disease and stage 3 kidney disease and diabetes, all of those things, that means multi-body system problems. And, you know, the old song about the knee bone being connected to the thigh bone, every single one of our organs is interdependent. It's not possible to have heart disease without some impact on your lungs and your kidneys, vice versa. General decline and increased need for support. If the people you're serving are needing more and more resources, does that mean that they've taken a turn for the worse and it's time to consider hospice? Again, words like unstable, deteriorating, complex symptom burden. And the biggest one, which we've already hit on before, is decreasing response to treatment. They are symptomatic despite everything. Doesn't mean they've got bad doctors. It doesn't mean the hospital didn't do their job. It means that modern healthcare has limits to what we can do in the face of an organ failing. And organ failure is not a sudden spontaneous event. With heart disease, lung disease, kidney disease, most forms of neurological disease, it's a slow progress. And picking out that moment at which the patient has taken a turn into end stage is so key, because we rely on everyone in the patient's environment to be alert to this, because nobody likes to talk about it. And all too often, the doctors only see the patients every 3 to 6 months. They don't feel comfortable being the ones to say, hey, there's a change. The hospitals often don't feel comfortable. And the result is that nobody talks to the patient about it until they're in the last 13 days of life. So next slide, please. Okay, some more general indicators. Progressive weight loss of greater than 10% over the last 6 months. Most of us would give our right leg to have that. But if you, again, think about the population of people we're serving, these are people who've had long-term chronic illness. They don't have a lot of nutritional reserves. When we start to see this weight loss, it means that despite their nutritional intake, their body is taxing itself beyond what they can take in. So their body is pulling calcium and minerals from their bones. It's pulling protein from their muscles. We've all seen the little teeny tiny chronically ill people who weigh 90 pounds and look like, a wind would blow them over. These are the people we're talking about. That's a very, very potent indicator of end-stage illness, and that crosses several diagnostic categories, and we'll see that again in a little bit. Repeated unplanned hospital admissions. Hospitals are being penalized for people coming back and back and back and back. And the solution to that is often to dump them into the correct healthcare milieu, to make sure that if they are end-stage illness patients, that rather than being sent back for aggressive treatment that's not going to change their outcome, they get the supportive care and comfort care that they do need. A serum albumin of less than 2.5. Again, that's a blood test that essentially measures the quality of your nutrition. If you're below 2.5, your body is trying to pull off its own reserves, and that is a sign of end stage. A sentinel event, and we fail to recognize these all too often. Someone can be doing quite well and then have a fall, or be placed because they can't take care of themselves, or lose someone they love. And that has an impact on their mortality as well. Okay, next slide, please. Okay, general indicators. If a patient is declining over months, he or she probably has months left to live. If a patient is declining over weeks, he or she probably has weeks left to live. And if a patient is declining over days, he or she probably has days left to live. So never underestimate that sudden functional decline. It is telling you something very, very, very important. And it is a sign that services need to be mobilized for the patient. Next slide, please. Okay, let's talk a little bit about cancer, because you will encounter people with cancer. And as I know that you know from previous presentations, not all cancers are created equal. There are a great many cancers where people can live long lives in remission. There are a great many treatable cancers. But cancer that is end stage is generally indicated by a fairly rapid and predictable decline. Metastatic cancer, cancer that starts in one place and moves to another, is often an indicator of a short prognosis. And again, believe it or not, the most important clinical indicator is performance status and mobility and functional ability. If the patient is spending more and more time in bed or lying down, if they're spending more than 50% of their time down and out, prognosis is generally 3 months or less. So it's something that you don't need scans to show. It's something that you don't need a doctor to show. Functional ability tells a huge story. Next slide, please. Okay, COPD stands for chronic obstructive pulmonary disease. This is a whole syndrome. It encompasses chronic asthma, chronic emphysema. basically irreversible pulmonary damage. It often has a very erratic decline, and this is why you might see patients, I often equate these patients to super balls. You know, they hit the floor and they bounce back up. But if you watch a super ball, as time goes on, the bounces get less high, and then eventually they stop altogether. So it can be tough with these folks to figure out when they're truly entering their end stage. But the key is abnormal lab testing, and I'm not going to get into too much of that because that's on the chemical and pulmonary level, but recurrent hospitalizations. If you get the patient, again, the 3 or more in the last 12 months for the same problem, if you think about it, quite logically, that tells us the person is getting worse instead of better because they keep having the same problems. And a lot of patients believe, oh, you know, I got that again. I just had that. I was just in the hospital with that. It's this, you know, it's not like you catch COPD and it goes away. The patient has damaged lungs. They're more likely to have repeat pneumonias. Signs and symptoms of right-sided heart failure. Right-sided, again, I don't want you guys to be feeling like you have to be able to diagnose that, but going back to the idea that if the lungs don't work, it impacts the heart. And if you're starting to see the signs and symptoms of the right-sided heart failure, it tells us that the heart is starting to fail. The more the heart fails, the less blood it can pump through the lungs. The less blood the lungs get, the worse the lungs do. Shortness of breath with ambulation greater than 30 feet. That's half of our population of the chronically ill, but that's a fairly potent indicator. And more than 6 weeks of systemic steroid use in the last 6 months, and recurrent upper respiratory infections. Those last two generally go hand in hand. And again, what I want you to take from that is this: if this patient is cycling back and forth to the hospital with the same set of troubles, that's a sign that things are getting worse, and we might need to talk about advanced planning. We might need to talk about options for care. Next slide, please. Okay, CHF is congestive heart failure. A lot of cardiologists don't even use the word congestive anymore. It's just called heart failure. Your heart's a muscle that has been beating since shortly after conception. All of us who've ever tried to exercise know that as time goes on, your muscles just can't do what they used to do. The heart is a perfect example. Again, it's impacted by the kidneys, it's impacted by the lungs. Heart failure basically means for one reason or another, the muscle is just worn out. And while there are drugs you can give, there's only so much you can do. New York Heart Association Class 3 is symptomatic with minimal exertion. Somebody who puffs going across the room, somebody who gets out of breath getting dressed. Repeated hospitalizations, recurrent symptoms despite optimal medical management. That's a lot of our heart failure population, and frankly, most of our heart failure population could benefit from hospice referral a lot quicker than they get it, but it's the #1 cause of death in America. And it is one of the biggest diagnoses for which hospitals are currently being penalized for readmission, which tells us that no matter where we send these patients, they're not getting the symptom management they need. And just a little aside about heart failure and hospice, patients who come on hospice for heart failure tend to live an average of 6 weeks longer than patients who don't. And that's simply because we're watching the symptoms. We're treating the symptoms, and the result is that the patient feels better and does better for longer. So there's a comment here that the secondary indications include an ejection fraction of 20% or less. That's not something I'm going to be hoping you guys will dig out of somebody's patient history, but it's just a little fact to know that if their heart is basically pumping only 20% of the fluid that it should be, their heart is not working terribly well. So next slide, please. And again, these folks, the patients with the cardiac and the pulmonary, these are a lot of those people who are in the SNFs, the people who are sort of stuck in limbo there. That's not to say everyone you see is going to be an appropriate hospice referral, but when you see these diseases, I want you to think in some part of your mind, these are chronic illnesses for which there is an end stage. Should we talk now about that plan? There's nothing wrong with that. There's nothing wrong with saying that your transition plan is to get you home, but this is a disease that will get worse at some point. Why don't you tell me now what things you do and don't want if the disease gets bad? Neurological disease, you'll see a lot of folks with this. This is your Parkinson's patients. This is your ALS patients. These are the people, again, it's a protracted chronic illness. People have a long period of time where they are chronically ill and can manage well at home, but they will come to the point where they're going to be end stage. How do we plan, and how do we keep an eye on the symptoms? Progressive deterioration despite optimal therapy. And you'll notice that that's the theme. Despite optimal therapy, things still get worse. A change from walking to being bedbound. Increased personal care support needs. A change from pureed to a pureed diet or artificial feeding. Again, with the complex, poorly controlled symptoms. Swallowing difficulty with these folks generally leads to aspiration pneumonia, sepsis, which is a systemic infection. They start with pneumonia and then it spreads to their entire body system, or respiratory failure. And again, it's heartbreaking to be called into the ICU to extubate somebody because they never wanted to be intubated. So these are very important discussions to have with anybody with a neurological illness. When it gets to the point where you can't breathe on your own, when it gets to the point, if it gets to the point that you have repeated pneumonias, what is the plan? Okay, next slide, please. Okay, dementia. Again, you're going to see a lot of folks with dementia. Dementia is a long, protracted disease. People can live a decade from start to finish, and much of that time can be spent being independent or with some support. So how do we recognize when these folks are entering their end stage? Those of you who've worked with dementia patients are probably familiar with the FAST scale. This is a scale that's designed to track the progress of dementia. 7C is someone who is unable to ambulate, is incontinent of bowel and bladder, able to speak fewer than 5 to 6 words in a day. So that's somebody who's fairly advanced if you consider that the FAST score starts with A, which is where we all hope, starts with 1 and starts with A, so we all hope we're up there. You can be a 7C for quite some time. There are a lot of people in our communities who are 7C being cared for by loved ones or being cared for in facilities. The transition to end stage is generally demonstrated by aspiration pneumonia, weight loss, there's our friend the weight loss again, urosepsis, infection starting in the urinary system and spreading, recurrent fever, and pressure ulcers. There's an idea that pressure ulcers are all preventable. When someone is in end stage, their skin is an organ, and when that organ fails, you will see pressure ulcers. Okay, next slide, please. Okay, so why don't we talk about this? Well, a lot of people say that's going to scare the patients. Don't talk to them, they'll be scared. Studies have shown that failing to discuss it is more detrimental to the patient's emotional health, and I will tell you that most patients who are end stage know it, and there is nothing more frightening than believing you're about to die and having nobody be willing to talk to you about it. The patient and family want everything done. Again, that's an educational issue. What does that look like to you? Do you understand what CPR is? Do you understand what intubation is? Do you have an advance directive? And I don't know what to say. If you aren't comfortable asking the patient about their wishes and telling them about their options, you can call, again, in our area, our organization, or any hospice and say this patient might be appropriate. Ask the patient if they want to talk about it, and you can ask the organization to set up a meeting. Okay, next slide, please. Okay, can we go back to the slides we missed? I think that would have been about the 4th or 5th slide. I apologize for jumping around, but I wanted to give you the baseline first, and I'll say when. One more? Okay, there we go. Yep, okay. Okay. We talked about that. One more slide forward, please. One more? Okay, so what does hospice offer? Where do we fit into the framework of the caregivers that are out there? Well, we are unique in that we are mandated to provide not only physical but psychological and spiritual care to patients. That's what makes us a little bit different than most other healthcare organizations. We all preach the holistic, but we are really able to do that from an interdisciplinary standpoint. All patients get a registered nurse to manage their symptoms and their physical needs. All patients get a social worker to assist with their emotional issues, including preparing for death, making closure, managing finances, and navigating insurances. That's very key because, unfortunately, if you think hospice has a bad rap in our healthcare society, social work has a worse one. Most families will say, we don't need a social worker, there's nothing wrong with us. It's because the patient has never died before, and it's unique to everyone. And it's because the families have never lost their loved ones before. So we're there to help with the emotional as well as the financial and the social. All patients are offered spiritual care providers to minister to their spirit, not their religion, but their spirit. So when a patient is referred for hospice, regardless of their setting, we bring in an interdisciplinary team so that we can truly do holistic care. Next slide, please. Okay, volunteers. Again, something unique to hospice. These are unpaid people who assist with non-physical care needs. They can run errands, they can do socialization, respite for the caregiver, very difficult thing to get at home. We can't do like a month, but we can, if the caregiver needs to go get their hair cut or attend to their own medical appointments, we can send a volunteer in to sit with the patient. It is important to note that, like most community organizations, we are not custodial care. We are an intermittent care service. The patient either needs to be able to maintain themselves at home alone or with their current support system. But we are one more layer. So if there are people who are at home, who are receiving some community services, and indeed we're already taking care of a lot of those patients, if they need hospice, we can be an extra layer of care, one more group of people coming to support and teach. I will tell you now that we get a lot of people who do live alone and who don't have caregivers, who make a decision that as they have lived is how they want to die. It's not ideal, but we support people's right to make that decision, and we will provide care to them in any way that we can. I will also tell you, death is a very personal moment. Most people, if given a choice, prefer to die by themselves. So we tend to have a sense, oh my God, you can't be by yourself, what if you die tonight? That may well be what they want and how they want it to be, and being able to provide that for them is a final gift. Bereavement support. This is also important. We provide 1 year, actually 13 months of follow-up to the family and caregivers of the patient to ensure adjustment to loss. And again, that's something else that sets us apart from a lot of areas of healthcare. We recognize that people may be just fine for the first year, and then the first anniversary comes up. But we get them through a year of all of the holidays, of all of the milestones, that first birthday without the patient, that first Christmas, and make sure that they're doing all right. We provide everything from one-to-one counseling, if that's what the person needs, to support groups. And again, all of these things, these are standard hospice. You might find slight variations geographically, but all hospices are mandated to provide these services. And all members of the hospice team work with the patient, the family, and the primary doctor to deliver quality end-of-life care. Also important to know is that we do not pull people out of their existing community health network. Their doctor remains their doctor. With a very few exceptions, most patients can continue with the community services that are in place and have hospice. The reason for that is usually we're billing Medicare, so unless the entity providing the support is also billing Medicare, we're generally fine. If a patient only has Medicaid, if we're not duplicating services, we're generally fine. So that's just something good to know. As these programs evolve, I think we're going to all be tripping over each other a little bit, saying, oh, can I do this, you do this, you know. But the important thing is as people change, they're going to need more and different services, and the more we can collaborate to bring those services, the better off the patient will be. Okay, so next slide, please. Okay, so how do we help? I mean, what's the use of having hospice in? The big thing, and I cannot overemphasize this, is establishing normalcy. We are often the very first people to say to the patient, you know, you are going to die. Our job is to help them live as long as they can, as well as they can, with good symptom management. And when that time is up, that they die in the place of their choice, with the level of care of their choice, in comfort. Assessing the symptoms. Symptom management is what hospice is all about. What is bothering the patient? What is bothering the family? And what steps can they take to feel better? What steps can we help them take? That may be anything from pain management, which usually occurs with a lot of cancer patients. Once we relieve their pain by adjusting their medications to a degree that is comfortable for them without causing them to, you know, be woozy all the time. For people with respiratory illness, it's managing their shortness of breath, helping them manage their activities of daily living, help them maximize the benefit of the medications that they're taking, help them recognize the triggers that cause them to feel sicker and try to reverse those triggers. With heart disease, it's generally managing fluid overload. By helping people to weigh themselves every day, take their meds correctly, and follow their diet, we see our cardiac patients do better for longer. I mean, to be honest with you, the average length of stay for our cardiac patients is usually closer to a year, simply because when they feel better, they do better. Dementia patients, you know, obviously most folks with advanced dementia cannot tell you what they're thinking or feeling, but that's why you have to be very attuned to their behaviors. You know, figuring out if they have a urinary tract infection, figuring out what are the triggers that cause them to become anxious or engage in repetitive behavior. How can we intervene on those symptoms before they occur? And it's not always medication management. A lot of it is behavioral. The other big thing we do is refocus the care. We try to address today. What's the most important thing to you today? How do we make today be the best day that it can be? And we try to prepare the patients and families every step of the way for what's going to happen next, so that when they see that next decline, you know, if a patient is up and walking, that's when we start talking about what's going to happen when you can't walk. When a patient is continent is the time to talk about what's going to happen when you become incontinent. When they're eating beautifully is the time to talk about what's going to happen when you can't eat. So that every step of the way, the patient and the family, when that next stage comes, say, oh yes, we talked about this, I have my plan in place, I know what to do about this. So next slide, please. Okay, and this is where we picked up with the eligibility versus reality. We've got about 11 minutes left, so I'd like to go to the very last slide, if you could, please. And I apologize for flickering all over the place here. It just, the presentation worked better when we hit the symptoms first. These are just a few ads for our local service. The final thought for this, and this is a quote from Dame Cicely Saunders, who is the founder of Modern Hospice. You matter because you are you, and you matter to the end of your life. We will do all that we can, not only to help you die peacefully, but also to live until you die. And that is the essence of hospice. We are not there to hasten death. We are not there to artificially prolong life. We are there to make every day that's left matter. So I'll now take questions if anybody has any.
I'm not going to try and unmute everyone all at once because that was disastrous the last time I did that, but I was able to unmute one person at a time. So if you would like to ask a question, feel free to do it through the question box, or if you just say, I think Elijah raised his hand or something. It showed me a little symbol that I clicked on. And then I just unmuted him and he was able to speak. So feel free to do that, raise your hand or ask a question. So while we're waiting for people to ask their questions, I'll just say that the pain management is really important, and that so often doctors are thinking in terms of, well, we don't want to get them addicted, or we don't want to have them, so medicated that they can't drive or operate heavy machinery. And really, those concerns aren't as important when somebody's at the end of their lives. And just being comfortable is really, really quite important. I know I had a personal experience where the person was not being given adequate pain management, and then as soon as the medications were in place, or I should say the right medications were in place, his entire mood changed. It was just so amazing what the cognitive difference was when the pain was reduced.
Well, yeah. I mean, when somebody has, like we always say, if this is all the time you have left, not 1 second should be spent in pain. And there's a lot of misinformation about narcotics out there. The actual incidence of addiction among people who are appropriately prescribed narcotics is less than 1%. And these patients, again, if they have a prognosis of 6 months or less, the idea of them becoming addicted, they're not going to be selling their drugs on the street, they're not going to be inappropriately seeking. But if we can control their pain, generally what happens is a better quality of life and a better function, because now they can move, now they can stand up, now they can eat, now they can sleep, and all of those things contribute to somebody who does much better. So yes, pain management is key, and that's something that we are specialists in.
Well, I don't see any questions. I know people must have questions.
I think I could add something to that from my oncology background as well. This is Laura speaking, is that many of the people that we treated at the oncology office I was at went through their treatments and then transitioned to hospice when the time came. And the doctors that I worked with were very respectful and always listened to the people in the hospice care arena as far as what was needed for pain management. It took me a few years to figure out that the doses that they were writing for, even though they seemed so phenomenal to me, in that particular arena, they were appropriate, and I learned to trust that.
Yep. And it's, when people are at end stage, their bodies do all sorts of things, and it's not just the cancer. You will see people with heart disease who have horrible pain at end of life. It's because all of our systems are kind of shutting down at once, and our neurological system, which is the one that tells us if we're in pain or not, is also being irritated and set off by all of the other biochemical events in our body. And again, going back to the theme that I've preached throughout, you cannot look at any body system in isolation. Everything impacts everything. And when you make someone comfortable, they do much better.
The other thing that I would say about hospice is that it really it is a take what you want kind of attitude that all the staff have. So, they do come in and they do offer a large number of things that they can help with, but it's all about what the individual wants. So you can say, I'd rather not have, let's say, the spiritual person come in, or I'd rather not have the volunteers, or whatever it might be. It really is specific to the individual and what they do or don't want.
Absolutely. And I think everybody who works in the community setting has discovered or will discover that once you are on the patient's turf, it's a whole different ballgame. And having people advocate and pick and choose and say, these are the pieces that interest me, these are the things I want, these are the things I don't want. When patients are empowered to make those choices, that alone is just so good for them, to be able to live life on their own terms.
And Elijah, I think I've unmuted you. You had a question?
Yes. My question was, how soon should a loved one contact hospice? Because not everyone experiences a rapid decline. Sometimes it comes in like say for instance, if a person has congestive heart failure and they've been to doctors multiple times and the doctors have discharged them home, but the person you can see that the person is experiencing a gradual decline, over time. Would it be valid to contact a hospice care provider in that case?
I would say yes. My motto for hospice is there's no time like the present.
Okay.
Because most people err on the wrong side of believing if somebody has 6 months or less, and doctors are among the worst. And I don't mean that as a criticism. It's
Sure.
Studies have shown that the longer a doctor knows a patient, the less objective they are about their condition, and that with cardiac patients in particular, when asked to prognosticate, doctors are wrong more often than they're right. Again, not to say that doctors don't know what they're talking about. It's saying that if the doctor doesn't know, how can anyone else? Generally, I advise people, if you think you might want to talk to us now. Hospices do what's called an informational visit. So it's a no-charge visit where we come and talk to the patient and the family. And the hospices can also do a lot of the behind-the-scenes work. If the family wants to talk to us, we will come make an informational visit, and then we can talk to the doctor and say, hey, the family has contacted us. Can you send us your medical records? And then we can sort of make a determination as to whether the patient is appropriate. A lot of hospices now have palliative care programs. So if somebody is either not quite clinically ready or not quite mentally ready for hospice, but wants to sort of have a little bit of a connection or have some symptom management advice, they can have that as well. So.
Okay, thank you.
You're welcome.
And can you just explain what the difference is between hospice in the hospital versus hospice in your home?
Okay, that's a very good question. Hospice home care is for anybody with a prognosis of 6 months or less who wants comfort care and symptom management. Hospice generally comes from one of two ways. Either we have a patient in the community, and despite everyone's best efforts, their symptoms are so out of control that they require a hospital level of care. If the patient is in agreement, the hospice can transfer the patient to the hospital, treat the symptom in that setting without any other involvement. They are not suddenly, full codes. They are not being subjected to testing. They are there as a hospice patient for, say, IV pain control to get transitioned to a pump, or perhaps they had intractable vomiting and that needed to be treated via IV before they could go home on a PO, an oral regimen again. Maybe it's somebody with a brain tumor who's having uncontrollable seizures, and we need to get those seizures under control and get them home. So that's one way. The other way, and we're seeing it increasingly, is hospitals calling us and saying, we have an end-stage patient here. They are expressing that, either they or the family, there's no more that we can do for them, and they don't want to go to the ICU and be intubated. However, they are on intravenous pain meds. They can't go home in this situation. We will come into the hospital, admit the patient as a hospice patient, and then they become a hospice patient who just happens to be living in the hospital. They get the care of the hospital, the 24/7 care from the nurses and the doctors. They get whatever intravenous medications they need for comfort, but they're no longer subjected to any tests. They're no longer getting vital signs. It's strictly a comfort care situation, and usually the patient will pass away in the hospital. Examples of that are usually people with incredible end-stage pain control needs, where they're on intravenous morphine and they're requiring more and more and more, so it's just not possible to transition them home, and it's not feasible to transition them to oral medications because they can no longer swallow and they're actively dying. In that case, we keep them in the hospital in that controlled environment where they can be supported.
Oh, thank you.
Oh, you're welcome.
So you have perfect timing. It looks like it's exactly 2:00, and it seems like we've gotten all our questions answered. But Suzanne, I really appreciate the time. And hospice care is an important service that we can provide for people that we're serving and helping getting out of nursing homes. So thank you very much for your presentation.
You're welcome, and thank you all for attending.